So friends, let us begin with this session, and the session is Ranibizumab, the versatile antivascular endothelial growth factors. Well, it's more than a decade that we had anti-VEGF available with us. I remember when I initiated my fellowship program, and we used to get a cases of age-related macular degeneration, so a weight variant of it, we would say that we cannot do much. Then came the lasers, where we started lasering these particular membranes and ending up with a scar, with a consolation that we could prevent further visual loss, but for the recurrences. So that is the way it started. And then came the pharmacology for the rescue of vitreoretinal surgeons. Initially came the steroids, and I'm thankful. Okay, I do welcome Dr. Arnab Das and Mahesh Gopal Krishnan to be with me over here. So, Talwar sir, you can meanwhile load your presentation on number 1. So when macular anti-VEGF came, it came in a big way. Initially, the prices were quite high. They were really restrictive in means, for the routine practice in our Indian context. And from there, it has moved. The prices have come down. They have become competitive, and they have become affordable to the most of the patients. And that is how this was the second anti-VEGF which had become available to us, and we started speaking for the patients that we can improvise the vision. Not just, we were never on a defensive henceforth. We became more aggressive, we thought about, and we started speaking about improvement in the vision, the quality of vision as well. Now we have a big bucket list of, I should say, of anti-VEGFs, but in spite of that, even now the Ranibizumab, which was the originator molecule, is holding the sway and is holding the major market share. And why? Basically because this is the original research molecule which has been introduced. For the first time, it's more of a target specific thing. And that's why in this era, when there are so much of competition and other anti-VEGF molecules working through other mechanisms, it is still holding the sway. So let us hear through some of our speakers how this molecule helps us out in various diseases like AMD, diabetic macular edema secondaries to any vascular retinopathies, and sometimes tumors as well. So without much ado, I would introduce you to my panelist, Dr. Mahesh Gopal Krishnan, who is from Kerala, Cochin. He is a senior vitreoretinal surgeon at Girdhar Eye Institute. And my next co-panelist is going to be Dr. Arnab Das from Kolkata. So may I take this privilege to introduce Dr. Dinesh Talwar sir and invite him to speak on his experience of Ranibizumab as first-line agent in retinal disorders. Dr. Dinesh Talwar is one of the most respected and most sought after vitreoretinal surgeon as a speaker and an academician who can really tear us apart, all of us.
Thank you, Prashant. Intravitreal agents have revolutionized the treatment of retinal diseases. And this journey began long, long ago. This is my disclaimer and my financial disclosure. Before I start, I want to acknowledge my debt of gratitude to Professor Bipin Chandra, who is no more, but who gently guided and encouraged me to continue my pursuit for successful management of age-related macular degeneration throughout his life. And actually, his lifetime over the last 20 years before he passed away was actually coterminous with the development of anti-VEGF drugs in this country. The anti-VEGF journey actually began with Marina and Anchor, which showed sustained visual acuity gains with monthly Ranibizumab. And for the first time in world literature, we managed to have improvements in our patients with age-related macular degeneration, rather than consoling them that your rate of deterioration will become less, and therefore you will go blind more slowly than you usually do. This regime was monthly and was the gold standard till some time back. And at that time, when this started, Ranibizumab was the only drug available, initially for exudative age-related macular degeneration, and then for various other forms of choroidal neovascularization, diabetic macular edema, then developed for BRVO and CRVO with macular edema. So if you talk about first line, we all started with ranibizumab as first line for a long, long time because there really wasn't a second line. However, now we have other drugs which have come. Other than bevacizumab, we also have aflibercept, and we have brolucizumab, and we have faricimab. So there's a lot of treatment modalities which are available to us today. How have these advances in management protocols changed the current approach to treatment? Well, as far as therapy for with anti-VEGFs is concerned, the optimization of management for exudative AMD is a combination of the drug used and the schedule of retreatment. And a lot of parameters are used to decide that, how you will use them. The ranibizumab as a first-line therapy for exudative macular degeneration was found in the EXCITE study to be adequate for 40% of patients on a quarterly basis. That means the 12 weekly injections that we talk about, even with ranibizumab, the same are possible in 40% of your patients. How you use it today, I'm not talking of the old times, I'm talking of now, depends on the type of lesion. If you talk of type 2 CNVMs, what we used to call classic CNVMs before, ranibizumab is extremely effective, and even today is my first-line drug. For type 1 CNVMs, aflibercept is probably more effective than ranibizumab, but you could use ranibizumab for both initiation and maintenance of therapy in patients who have economic constraints, and I will explain to you how. It's effective in many of these patients, but may require more frequent injection use, maybe once in 6 to 8 weeks, though, as I showed you, some 40% of the patients may have adequate response to even 8 weekly or more treatment. The rival study compared ranibizumab with aflibercept on a treat and extend basis and found that the visual outcomes were more or less the same with both the drugs. So was the number of injections needed, and most importantly, the number of patients who went up to 12 weekly or more injections was also more or less the same. Around 30 to 40% is the generally the figure given. Today, how do I manage my patients? I manage my patients with a loading dose, either of ranibizumab or aflibercept. I give 3 injections. If the lesion becomes dry, I have 2 options. For my one-eyed patients, I keep them on a treat and extend treatment, whereas with my 2-eyed patients, I would put them on what we call the PRN treatment. If a recurrence occurs within the next 3 months or whenever I treat it, if it doesn't occur, after 3 more months, I will increase the duration between follow-ups, initially to 6 weeks, then 8 weeks, then 10 weeks. But once in 12-week follow-up must continue lifelong. Patients who need a PRN treatment more than once in 8 weeks, say 6 weeks, 4 weeks, those are the ones I would consider a change to aflibercept. Just to show you, I mean, you may be wondering, ये तो होता ही होगा फिर सब में? No. You see this patient who had an occult CNV with a SRF, and this was one of my patients whom actually after giving the first injection, I had no option but to stop because it was absolutely okay. And for the next 1 year, the patient did not need an injection. So there are patients who will respond to maybe even 2 doses. Even I could not complete a loading dose because there was no further need for an injection. On the other hand, after your first 3 loading doses, there will be patients who are stable but not dry. They have some fluid. Intraretinal fluid is there or a little bit of subretinal fluid is there, and it refuses to go away. Now you give, next 3 months you give the injections, and if during this period, the lesion dries. Now, if it dries, you go back to the first algorithm where you treat with PRN treatment. But supposing it doesn't dry in 6 months, now at the end of 6 months, I will consider, if it is stable, no change in the OCT, no change in vision, I will put this patient into a treat and extend regime. Slowly increase the duration of interval by 2 weeks. With ranibizumab, you should not increase by 4 weeks. You should increase the interval only by 2 weeks at a time and see how the patient is doing. And then if I can reach a quarterly injection, that once in 12 weeks, that's a very good level, and you can maintain the patient at that level. If, however, the injections are needed more frequently, you may need to change the pattern to aflibercept. Now, once you've treated, you gave the injection, still some fluid is there, you treat it again, still some fluid is there. Now you treat it, fluid's gone. Should I stop the treatment? No. You give at least one more injection so that you have 2 consecutive OCTs with no fluid, no change, before you say, now I can put on a PRN treatment and not treat. The important thing is, even with ranibizumab, if you are optimizing the frequency of monitoring, your results will improve. So if you say, okay, you are okay now, come once in 3 months, you are doomed to failure, more or less. The Sailor trial showed that the patients followed up 3 monthly, whatever were the gains in the beginning, at the end of the loading dose, were all off by the end of the year. So what do you need? You need monthly follow-ups. Not monthly treatment, monthly follow-ups, and very stringent guidelines for retreatment. If the patient has any decrease in vision, any OCT fluid, evidence of new fluid, any increase in thickness, any new macular hemorrhage, no fluid, but macular hemorrhage, small hemorrhage, new hemorrhage is there. So fundus photograph is important. Or any subjective evidence of macular fluid, treat this patient. Your vision results will improve. Remember, now see this, I was going to show you when I use it as a first line basis. This is first line. You have a patient, this is a classic CNVM, type 1 CNVM, given a loading dose 1, given 2. No further treatment is needed. This is a type 2 CNVM. Excellent response to treatment. This is another patient. This was a myopic CNVM. You see a CNVM here, disappears. One more injection was given. Next 1 year, no injection needed. And then developed an early recurrence, again treated, disappeared, lesion is all right. And then again for 3 months, nothing, given 2 injections, and has been all right for 4 years. In myopic CNVMs, ranibizumab alone is more than sufficient in most of the patients for a long, long time. This is another patient who had an inflammatory CNVM. He was all right. He had only this kind of scar tissue, developed this activity, needed 4 consecutive injections, and then became all right. And subsequently has needed only 2 to 3 injections per year to maintain. So inflammatory CNVMs is another condition where ranibizumab is adequate for treatment. You don't need to go anything further than this. And finally, there are some patients who have scar tissue with activity, like you see over here. Now you may say, why are you treating? This patient has 624 vision. This is good vision. You want to salvage this vision. You want to maintain this vision. And so we give this patient ranibizumab. Once in 12 weeks, she needs an injection. She's maintaining between 618 to 612 vision and is gone on for the last 5 years. So you can, again in these patients, maintain patients on ranibizumab alone. Now you may say, well, this is your anecdotal evidence. Is this actually working? Let's look at this. This is a study of long-term outcomes of treat and extend regime using ranibizumab, aflibercept, and bevacizumab. And you know what they found? No difference in visual outcomes with the number of injections between the agents used. Not only that, they also showed that the kind of fluid was also the same. The degree of persistence of the fluid was also the same, regardless of whichever drug was used. But most important, what made the difference? What made the difference was the number of injections, the duration of treatment. The longer the patient was treated, the more the number of injections, the better the response. So the eyes that gained more than 2 lines, were those which received more injections. The eyes which had visual acuity of more than 220 by 200 at the last follow-up had received treatment over a longer period, average of 3 years versus 2 years for the others. Greater number of injections, 23 versus 14. So it is not which drug, it is use the drug properly. So ranibizumab is adequate if your patient can't afford any other drug, and you can get the same outcomes. And this is a study from a Western country. They found giving 4 to 8 weekly injections of only ranibizumab, they could maintain better than 20 by 40 vision in 40% of the patients. 43% of these patients had better than 612 vision. And more than 64%, two-thirds of the patients had better than 618 vision. What more do we want? So don't tell your patient that if you can't afford aflibercept or faricimab, you're gone. No. You have lots of options available that can keep your patient going, and ranibizumab is a good option for these patients. So the basic principle you need to keep, no tolerance for fluid. We don't tolerate either intraretinal or subretinal fluid unless it's completely unresponsive to treatment, and then it's a stable situation, accept that. Sub-RPE fluid, don't bother about it. You don't have to go after it. It doesn't go away with ranibizumab. But any increase in fluid must not be tolerated. So aggressive treatment can give you effective results. But the important thing is regular follow-up, high index of suspicion for retreatment. Remember, ladies and gentlemen, eternal vigil is the price you pay for maintaining vision in patients with CNVMs. What about diabetic macular edema, the second big group? The utility was shown by the RESTORE, the DRCR-NET Protocol I, the RISE and RIDE, and Protocol T. All these drugs have shown its utility. The important thing to remember, the key message here is it's a finite disease. Number of injections decreases with time if proper treatment is given in the beginning. It's more intensive in the first year, less in the second year, and by the third year, there is resolution in many of the patients, or more than 60% or so. In fact, 25% of your patients will not need any injections in month 3 or 4, and these are elite responders. These patients will only need around 4 injections or so in the whole year. But this does not hold for everybody. There is another 25% of patients, there is another 20% of patients who will not respond. So don't keep wasting their money. Those are the patients you must shift to steroids. And there, a combination of the steroids with anti-VEGF agents may give you the best results. Which drug to use? Now you say, well, ranibizumab, old drug, does it work as well? Well, the question was answered by Protocol T. In patients who have better than 618 vision, both ranibizumab and aflibercept are effective. So these are the patients in whom I normally will start with ranibizumab, because there's no point in going to a higher level of drug when the lower one works. For patients whose vision is less than 618, aflibercept works better, and the initial aflibercept followed by ranibizumab for maintenance may be a better alternative. But patients who cannot afford aflibercept should be put on ranibizumab, not on bevacizumab. Why not on bevacizumab? This is to answer that. If you see the drying of the lesion in patients who have very good vision, this is Protocol T, the drying with bevacizumab is around 67 micron. Whereas with both aflibercept and ranibizumab, it's around double of that, 119 and 129 micron. So this is the reason why only in those who can afford nothing else, those are the patients where you go to bevacizumab. In the rest, the choice is of ranibizumab. Now, in patients who have poorer vision, but the thickness is less than 400 micron. Again, ranibizumab and aflibercept are equally effective. So even in patients who have, say, lower vision, normally you say lower vision, aflibercept. But no, lower vision, but the thickness is, say, less than 400 micron, ranibizumab is as good as aflibercept. And this is all protocol T. This is not me speaking anecdotally. In patients who have a thickness of more than 400 micron, those patients, aflibercept is better. So how do you go about now? You may have patients who had more than 400 thickness. The patient says, I can't afford so many drugs. I can't afford monotherapy with aflibercept. Remember, when you combine macular laser, focal macular laser with ranibizumab, the results are as good as aflibercept monotherapy. So, and this is again protocol T, not personal information. You see this here? Vision is less than 20/40, focal treatment done, same results in all the three groups. Vision is less than 20/40, but no laser done. Obviously, the best results are with aflibercept. So patients whom you want to do, and in fact, in our country, to bring down costs, I would suggest the best option is combination of AntiVEGF first, bring down the edema, focal macular laser then, and then followed up with PRN treatment with AntiVEGF agents. Ranibizumab would be adequate. Now, it's not as if you don't get results here. You see this patient, he developed macular edema, 1 injection ranibizumab given, responded. Incidentally, you know, I was interested in showing this because I keep getting people showing patients on brolucizumab. I gave 1 injection, became all right. This is ranibizumab, man. Treatment-naive patients with ranibizumab also respond as well. It's not that, it's just that the number of patients who respond like this will be less. But you can get the same good results with any of these drugs. So, 1 injection, patient responded. What about this? Horrible edema. Ranibizumab given, improved, given another one, improved further. Normal foveal contour. 3 injections it took. Normally they say 5, 6. Yes, in today's world, after 3 injections, if your patient is not responding, give an injection of steroid. Don't keep on waiting. Now look at this. This patient was worse, needed 5 injections. Edema given, little better, not much, not much. Finally decreased, came back, gave 1 more injection and responded. So 5 injections. Now how do you manage DME? In DME, if your vision is better than 6/9 or better than, and near vision is better than N8, you don't need to do anything. But if the vision is either less than 6/9 or near vision is less than N8. You see, this is very important. People don't talk about this near vision part, but remember, what happens in a macular disease? The near vision goes first. And what happens? He can't work. And you say, no, you are 6/9, I won't treat you. Hey, he's N12, man. Treat him. So either of these are indications for treatment. Then you see after 1 month, I'm sorry, this was DME. Now we come to BRVO. In BRVO, if the patient, the same actually holds for DME also, don't treat patients who have good near and distant vision. Treat them only if the vision goes down below 6/9 or below N8. But in patients who come to you with BRVO, now this is even more important because there is a tendency, edema hua, treat kar diya. No. If he comes within the first month and the near vision or distant vision is good, don't treat. He will become okay. If the near vision or distant vision are bad, then you need to give anti-VEGF agents. Presentation after 1 month, you see, he came to you after 1 month, near vision, distant vision bad, treat. If it's good, you don't need to do anything. So any increase is treated beyond 6/9 or N8. Now people will say, hey, how can you not treat? Now look at this. This is the Comrade study, not my data. It says if the patient presents even up to 60 days later, no difference in outcomes, right? So why are we in such a hurry? Most of these cases of BRVO will recanalize on their own, so don't be in a hurry to treatment. This was a patient who came with 6/12 vision, so we decided to treat. And you can see injection given, patient became all right. So here it's PRN treatment, 1 injection, patient's okay, forget it, no more. Now, after that, you follow up the patient. If he's okay, you don't need to treat. If there's a partial resolution or no resolution, you would need to give more injections. This is to show you another patient who did not respond. 1 injection, 2 injections, 3 injections, 4 injections, 5 injections, and finally we were forced to give Ozurdex. And with Ozurdex, the edema started coming down. So that will happen once in a while, even in BRVO, and that will happen with any of the drugs that you're using. So in BRVO management, initially ranibizumab, recurrence, ranibizumab. Third time recurrence occurs, give a combination of ranibizumab with quadrantic laser, especially if on FA you have more than 5 disc areas of capillary non-perfusion. And after that, if the patient still gets a recurrence, you have to think whether to shift. So this is just to show you one more patient, 1 injection given, improved a little bit, then became okay with the second one, stayed okay after this, again a recurrence, was treated, became all right, again recurrence. This time he was given a quadrantic laser. Along with that, became all right. Next recurrence, a macular grid was done, a modified grid. And then he has stayed okay since then for the last 7 years. So you have to have that patience to treat. When you are following up patients with recurrent treatment, on recurrent treatment, if the deterioration is less than 1 line, you can be conservative. But if it is more than 2 lines, you have to give either anti-VEGF agents or add steroids and use a treat and extend regime. Remember, now again you'll say, laser ka kya role hai? Again, not my data. Look at this. The brighter study showed that patients who had ranibizumab with laser, who had more than 12 months of duration, did better than those who did not get ranibizumab. See, this is the group without ranibizumab. This is the group with ranibizumab with laser. Again, in this situation, ranibizumab and aflibercept both work, and Ozurdex is a second line. Last group of patients, central retinal vein occlusion. This is a more dangerous situation. You do need to treat. Basically, the mainstay of treatment here, as ranibizumab was demonstrated by the cruise trial, and aflibercept also works. Both are effective, but it's not that ranibizumab will not work. It will work in this condition. Just to show you, this patient got 1 injection. With 1 injection, became all right. Became all right, got a recurrence sometime later, was again treated, again responded well, and then stayed all right. He stayed all right because the vein recanalized, not because the drug did anything. And the same applies regardless of whether you're using ranibizumab or aflibercept or any other drug. We don't make the patient okay. The recanalization, upar se aata hai, that makes it okay. So the initial treatment is anti-VEGFs and steroids in non-responders, laser in case these are ischemic. Ladies and gentlemen, I conclude by saying ranibizumab is still available to you as first-line therapy in many situations, including type 2 CNVMs, as I showed you, DME, RVOs, and in all patients requiring anti-VEGF treatment who have economic constraints. Thank you very much. Remember, a targeted approach, keeping in mind the lesion characteristics and the response of the lesion to treatment. Both are needed to ensure the highest quality of care at least cost to the society. Thank you very much.
That was typical Dr. Talwar taking help of evidence-based medicine. Just one point, probably the safest anti-VEGF currently in case of systemic problems, MI and stroke and all, is still ranibizumab, right?
Yes, so
that
now
is,
remember this. This is a very important thing that Mahesh is talking about. The only proven, validated drug for safe injection in a patient with a recent MI or a recent stroke is 0.3 milligrams of ranibizumab. None of the other drugs have been tested for that, so we don't know whether any of the other drugs are effective. And that's exactly what I do. If I have a patient with AMD where I have no choice but to go in, even if the patient was on aflibercept, I will shift him back to ranibizumab, 0.3 milligrams, for some time, and then shift back again.
yeah. Especially now, a lot of apprehensions are there, especially in nephropathy cases and all these things. This appears to be the safest one.
So
Then,
one question also I had. You spoke about whenever recurrences and need of further injection, the criteria was OCT based more than 100 microns. And also you said that subjective fluid assessment can be also a
Yes.
criteria. What do you mean by that?
Yes. So you know what happens is, see, this is very important. This last bit cannot be done by a physician who's seeing the patient for the first time. But when you've been seeing the patient month after month, you know, hey, this is not quite right. There seems to be some microcystic fluid here, which is not enough to form a well-defined cyst, but there is a problem. Even in that situation, it's better to be safe than sorry. That's what I mean. It's not that there is, see, what it means is, there's these very, very fine microcystic changes. It's not enough to now cause a well-defined 100 micron increase in thickness. But when you compare the two, you say, no, this is not quite okay. Something is worse. That's what I mean. And that can never be done by somebody who's seeing the patient for the first time, which is why it's very important that your patients follow up with you regularly.
If I have to add something on this, forget you seeing anything. It is the patient, if especially a one-eyed patient, he will tell you there is a distinct difference in what I saw last week and they will come and say, give me the injection. You don't even have to worry about it. You don't even have to do your OCT.
So you will have that occasional patient.
The one-eyed patient will follow up, will be after your blood, and he would want it.
So Dr. Bipin Chandra, whom I talked about, would actually come and say, he said, Dinesh, I think it's time for another injection. And sometimes I wouldn't be sure. But after the injection, he will say, "Theek ho gaya."
And if you wait within 1 or 2 weeks, you will start seeing changes in the OCT.
Yes. So don't ignore the patient. Especially if it's an intelligent patient, don't ignore the patient.
They come with the injection. They are clear, now I need the injection, forget the OCT. Especially
Only the second day, one eye is normal, there is problem. In those cases, I think the PRN appears to be the best. The other thing is DME and RVO, we need not be very stringent in our management. It is pardoning type of disease. And in many of the RVOs, I give one injection. Even if there is recurrence after 1 month, the vision may not become 6/60. It may be 6/9, 6/12. Then you observe it.
It may not even fall.
Yeah. So, especially TVO and all, there is no point in giving continuous injection. Final result will be due to recanalization of the,
See,
collaterals.
with BRVOs, don't be aggressive.
Yeah.
It's very important. For BRVOs, don't be aggressive. CRVO, you can be more aggressive. In BRVO, supposing you've given 4 injections and you find he's come back, just see if you don't give the injection, what happens. Very often you'll find nothing happens.
Yeah, basically neovascular AMD,
He just stayed
PCV
there
and
with a little bit
CRV
of
are the
edema.
aggressive diseases, not the RVOs. DME is somewhere in between. But sir, very well highlighted that since this neovascular AMD spectrum, PCV and wet AMD as well as CRVO are aggressive diseases, we need to deal with it aggressively initially. This is something that ophthalmologists sometimes tend to be loose on. And they talk of cost cutting from day one, but basically if you're not aggressive initially, you actually land up increasing the cost for the patient.
Yeah, so remember what I said. Very, very aggressive, not treatment. Very, very aggressive monitoring.
Yeah, but the
Every 4 weekly, see your patient.
Yes.
If you find anything negative, treat. Do not leave it alone. You will ensure that you give adequate treatment if you do that. And if you don't do that, unfortunately, you will give suboptimal treatment and the patient will have suboptimal results. And then you'll say injections don't work. And then you'll say Ranibizumab didn't work.
Arnav says is absolutely correct. Some of the general medical retina specialists, they give one injection of aflibercept, then 3 months later other one. Then the patient will come, though injection, there's no change. Because the protocol is totally wrong.
So most of the time patient will come to me, मुझे तो 5 injection लग गए, कुछ भी नहीं मिला. So I said, कब लगा था पहला? इसे 3 साल पहले. Last injection कब लगा था? 6 महीने पहले. तो मैंने कहा वो तो waste paper basket में फेंक दिया तुमने.
In fact, we go to the new generation injections just to increase the duration of activity, not because this first generation Ranibizumab is bad. It is still good. We are all using that.
Yeah. Basically, the newer anti-VEGFs are not better in efficacy. It is better in allowing us longer
Durable.
prolongs our
the basic thing is you want to pick up the ones who need that longer duration. Yeah. I told you 20% will not need anything else. They'll be okay with this. Now, why do you want to subject those 20% also to the most expensive drugs? First, try the simple thing. It doesn't work, you can always go to the higher thing. That's the important thing.
Okay. So we'll continue. Okay,
One
last
statement.
question.
Sometimes, I mean, if you feel that this is a very aggressive disease where you need a newer anti-VEGF to help you out, and the patient is his financial status doesn't allow you to continue with that, sometimes you can open with a strong anti-VEGF, the newer anti-VEGF, and then you can come down to ranibizumab.
I said that for DME.
Yeah.
That if you see the curve of the improvement, it's a little better with aflibercept than with the ranibizumab. But the plateau level is the same with each. So you can start with aflibercept and then shift to ranibizumab.
Yes. So
in diabetic macular
I
edema.
was trying to say the same.
Okay.
Correct, sir.
So thank you, Dr. Talwar, sir. Now, may I request Dr. Himanshu Mehta now to present his experience of anti-VEGF in a PDR management. Talwar,
Thank you,
sir.
Dr. Prashant.
Talwar, sir.
Good afternoon, friends. Just to let you know that there is no financial interest in this particular medication or any other of these pharma products from this company. I wish I had any, and I wish you all too had any, because this is a growing market, it's here to stay, and it's effective. It's not just marketing. So remember that Richard Bach statement, that there is no such thing as a problem without a gift for us in its hands. We seek problems because we need those gifts. And here it is, the role of anti-VEGF in PDR management. It's a very important thing. As you know, Dr. Talwar has managed to say a lot of good things. I will make it a lot brief for you so that I don't come in between your lunch and you. Just to mention a few basic things on etiopathogenesis of where we start, and that will make life a little easier, why you should be using it. The hyperglycemic factor and the biochemical reaction, the molecular which happens, the hexosamine pathway and the polyol pathway, the VEGF factor and the ANG2, you can realize these are things which are really changing. The understanding of the subject changed when we started. When we started practice, way back, we had nothing to offer to these patients, diabetics and or ARMD or BRVO. Macular edema, you couldn't go close, you couldn't do a grid, you could permanently destroy. The revolutionary treatment which came was once you had the anti-VEGF coming into the picture. So there is endothelial parasite loss and thickening of the basement membrane and leukocytosis, giving you macro and microvascular complication. The whole story is ischemia, ischemia, and ischemia. And the body is very smart. It wants to give it more blood. So when there is hypoxia, there is a stimulus of VEGF and neovascular formation. So the clinical features would be non-proliferative diabetic retinopathy, mild, moderate, severe, which you are aware of, that you have only microaneurysms, the intraretinal microvascular abnormalities, the ARMAs, and when widespread intraretinal hemorrhages and microaneurysms observed, these are the severe cases. Whereas the proliferative one, now quite often the patient directly comes with that because one eye was seeing well, and most often than not, they come like that. One eye was seeing well, so they never bothered closing their eyes, and we have PDR in one eye and a non-PDR in the other eye, characterized by retinal neovascularization, new blood vessels, they are likely to be fragile, and that is what the most important thing. And the worst scenario, as I give it to the patients, that it's like your Wankhede Stadium or the Firoz Shah Kotla Stadium. The stadium is okay, but the pitch is destroyed. In diabetic macular edema, it can occur with any diabetic retinopathy, but most likely to manifest following non-proliferative diabetic retinopathy. So what are the clinical features? The 50% of people with severe NPDR progress to proliferative within 1 year. So remember that, 50%, not a small percentage. And you know what is the kind of population with the Pizza Huts and all that we are going to be getting? India will become the diabetes capital of the world. Novartis shelled off its pharma division to JB, but they have not given off this. Why? Because this is the real egg which will lay the golden eggs for them. And so within what you can see, 50% getting NPDR to PDR, and within 1 year, and 25% of patients have PDR at least 15 years of diabetes duration, which means when I see some of these 20, 25-year-old diabetics without any diabetic retinopathy, I say your name has to go into the Guinness book. There is some gene which is protecting them. And there are these some 30-ish kind of people, 30, 35, terrible diabetes, and they have bleeding in both the eyes, and they're terrible. So we are not looked at that as yet, but that's something very important. So you have vitreous hemorrhage, you have fibrosis, you have vitreous or retinal detachment, and vision loss can occur as the diabetic retinopathy worsens from NPDR to PDR. Of course, that's the time they come to you. As the diabetic retinopathy progresses, abnormal blood vessels grow, mediated by the VEGF occurs, and the new vessels are fragile and prone. to hemorrhages, disruption vision, and causing scarring. Patients with PDR experience those spots in their field. They would say they are seeing something less, they are not very clear about the whole thing, but they don't know the severity of the whole thing. PDR is associated with high risk of visual morbidity arising from tractional retinal detachment. You will see small areas. Once fibrosis starts, small areas of tractional retinal detachments are there at the periphery when you're doing a B scan. And the problem is the patient doesn't understand the gravity of the situation, that how bad are they and where are they progressing. The eye really looks like on fire. Current unmet need and role of anti-VEGF in PDR. Of course, 40% of proliferative diabetic retinopathy do not respond to PRP treatment. 1/3 of the patients have recurrence of neovessels within 1 month of PRP, and PRP takes 3 months for complete regression. Whereas 4x increase for the vitrectomy compared to anti-VEGF, of course, when the moment you get that, there are high chances that you'll have to do vitrectomy and membrane peeling and the rest of the stuff. So PRP does not improve visual acuity, and vitreous surgery can lead to infection, all the problem that you can have. However, the role of VEGF throughout the spectrum of diabetic retinopathy provides a strong rationale for the use of anti-VEGF agents because the potential to prevent onset and recurrence of vision-threatening complications of diabetic retinopathy. Anti-VEGFs in PDR, there is a lot of evidence to suggest that. There is no question, everybody is convinced beyond doubt. When it came into the market, it was very difficult to believe that you have something which can not just protect your vision, but improve 1 or 2 lines. It was very difficult to digest at that time, that whether it was a marketing strategy by the company or whatever. But the fact is, all of us have seen it in our practice, that the moment you start, even a worst case of fibrotic, bleeding, vitreous hemorrhage, tractional retinal detachment, and proliferative diabetic retinopathy, the moment you've given a couple of injections, the eye really looks quiet. It stops progressing. You don't even have to do too much laser because the moment you do more laser, there'll be tractional retinal detachment happening further. So the study population which was there was 394 patients with PDR with or without DME, and the primary outcome measures was mean visual acuity changes after 5 years. Conclusion, they found that support either Ranibizumab or PRP as a viable treatment for patients with PDR, and better visual outcome achievements with Ranibizumab monotherapy in eyes with or without diabetic macular edema. There is no question about it that monotherapy, just plain without permanently damaging, scarring the retina, that can still work very well. So the RISE and the RIGHT study to evaluate the diabetic retinopathy outcomes with Ranibizumab treatment in patients with diabetic retinopathy and diabetic macular edema at a high-risk progression to proliferative disease. The study population was 746 patients with baseline fundus, more than or equal to 2 steps or more than equal to 3 steps improvement or worsening of the ETDRS. Remember the ETDRS study, the good old one, the DRSS and time to new proliferative events. So the conclusion there was intravitreal Ranibizumab reduced the risk of diabetic retinopathy progression. So diabetic retinopathy improvements were rapid, clinically meaningful, and sustained through month 36. As Dr. Talwar mentioned in his talk, time and again he mentioned how don't give up hope, start from the beginning. If you have a long time gap, like he said in the last patient which he mentioned, forget it that the past treatment was history. The company benefited, the patient did not benefit. It's an ongoing process. From day one, we have to explain to the patient that it's not a one-shot therapy. It's not like tetanus that 3 injection ho gaya, finish ho gaya baat. This is ongoing, something which is very difficult for patients to digest. So if I have to give you the answer, what I have to tell them is that it's like this, that Kasab came, Faisal came or Afzal came, they were destroyed, those terrorists were destroyed. But do you think somebody else can come still and do some terrorist masti in this country? Surely. Why? Because terrorism persists. So why did you take the injections? Believe me, most of them don't have the answer. Few of them come and tell you, yeah, it is possibly diabetes ki wajah se hua tha. So the moment you tell them and associate that it was diabetes responsible for this and say, has your diabetes gone? No. So you will need it. That is what is required for your treatment. So the RISE patients with more than 2-step improvement, as you can see in front of you, the sham study, the Ranibizumab 0.5 milligram crossover, you can see the arrow will go up, no question, and Ranibizumab treatment reduced the time to new PDR event in patients with DRSS 47 to 53 at baseline. I won't go into the graph further, but just to give you the baseline understanding, the protocol 1 evaluate effects of the intravitreal Ranibizumab or triamcinolone administered to treat DME or worsening of, as Dr. Talwar mentioned again, that you may also have to give triamcinolone, some steroid to reduce the inflammation. And that synergistic effect can really work very well when it's recalcitrant. Diabetic macular edema is your most recalcitrant treatment. This may work, that may work, this may work. You don't know which one will work. And you don't even know whether each one of them will work. So you can never promise. It has a mind of its own. So you will have to try various strategies, and you'll have to tell them from the beginning. So the study population, which was 538 eyes without PDR and 254 with PDR, 3-year cumulative probabilities for retinopathy worsening, primary outcome measure. And the conclusion was intravitreal ranibizumab appears to be associated with a reduced risk of diabetic retinopathy worsening in eyes with or without PDR. As you can see again, ranibizumab treatment is associated with a reduced risk of diabetic retinopathy worsening in eyes with or without PDR. You can see that very clearly here. Eyes without PDR at baseline and eyes with PDR at baseline. So treatment associated with ranibizumab definitely reduces the risk for diabetic retinopathy worsening, and we are all witness to it. To assess the efficacy and safety of ranibizumab with or without PRP compared to PRP alone in patients with PDR. So the population here was 106 patients, change in area of retinal neovascularization. Let me go to the conclusion. Ranibizumab showed stronger effects on neovascularization and leakage and areas of reduction while offering better visual acuity. This is the most important thing, is to save the pitch. Save the macula till the last day as much as we can. Results rather than PRP alone. So earlier it was PRP, PRP, PRP. From there it came to co-sharing. And now I would lay little more stress on anti-VEGFs and less on the laser burning of the retina. So superior outcome, mean changes in neovascularization area in the combination group compared to PRP alone. No question. At month 3, a combination of ranibizumab plus PRP was significantly more effective than the other, and pronounced improvement of the morphological parameters in the combination group compared to PRP alone. Strategies, well, what are the strategies for combination therapy? Anti-VEGF or PRP, what comes first? So in the study and the outcome which was done, the conclusion was clear that ranibizumab plus group showed clear advantage over that in the PRP plus group in the treatment of PDR. As I was mentioning, as we saw what the previous speaker also said, that no doubt about it that your PRP reduces, the results are much better. You start with the ranibizumab injection, anti-VEGF first, and then go on to your PRP later. A couple of cases that you can see, look at the edema and look at the post-injection. These are cases where you will see the edema there and recurrence of diabetic macular edema. Steroid responses also noted after second dose of intravitreal triamcinolone. Focal lasers were not considered as the FAZ, the foveal avascular zone was enlarged and distorted. As seen here, once you start giving the injection, it definitely gives rise to reduction in edema. And the clinical scenarios for anti-VEGF combination therapy in PDR management. PDR with DME, as per protocol as treatment with ranibizumab, reduce the risk of DME development, and there is wealth of data to support that anti-VEGF use in DME. PDR with no traction and patient with good compliance. This is the most important thing. How do we make the patient understand the importance of multiple injections, the economic warfare which is there, the relatives, and the dirty disease called diabetes, which is also affecting their kidney, their heart, their brain. By the time your treatment is going for 36 months to 4, 5, 6 years, quite a few of them have had a bypass, quite a few of them have had a kidney problem. So there are comorbidities which are going on simultaneously. So PDR with no traction in patient with good compliance. Prior study showed that better neovascularization regression and meaningful visual acuity and outcomes. So PDR with NVI, in case of poor regression with PRP, anti-VEGF can be considered as per the study treatment with anti-VEGF, resulted in complete regression at 6 weeks. So this is something important. So summary, diabetic retinopathy is emerging as a significant health problem. We are going towards 100 million diabetic patients in this country very shortly in the next decade, less than a decade. So PRP was the standard care, but have a high risk of tractional retinal detachment, hemorrhages, and visual field loss. Anti-VEGF, would you, if I have to ask, how many of you would prefer anti-VEGF in your eye compared to a PRP? Would anybody like to answer that question? Would you prefer a PRP or would you prefer an anti-VEGF? Yeah, I think it's a no-brainer whatsoever. So anti-VEGF induce regression of diabetic retinopathy in most patients, protocol S, right protocol. We have enough evidence to say that. And anti-VEGF in combination with PRP may be considered in following clinical conditions: PDR with DME, PDR with no traction in patient with good compliance, and PDR with neovascularization. Active PDR after complete PRP and PDR with vitreous hemorrhage also, which means essentially any diabetic at any stage when you also feel. One more thing that I would say is even if one eye, as sir was saying, that the vision is 6, I would say even if the vision is 660 and less in one eye and the other eye is good, don't miss out treating the bad eye. You never know which one will become good in the long run after 5 years. The good eye may become worse in a few years and the bad eye might be the one which is seeing. So don't give up hopes. Do give your treatment. It's the best shot that we can give to save whatever treatment we can. Ranibizumab followed by PRP results in better clinical outcomes than PRP followed by Ranibizumab. Thank you so much for your time.
So let us, the few take-home messages from the talk is, actually laser is a destructive treatment. It causes a lot of problems. That is why we are trying to reduce the laser. But in spite of that, laser is one of the first-line treatment in PDR, and anti-VEGF cannot be taken as a monotherapy in Indian patients at least, because the follow-up is extremely important. Even in protocol S 5-year follow-up, those who missing follow-up, they are disastrous. So anti-VEGF alone in a PDR is not a probable solution in India at least. So laser still holds, but we want to reduce the laser because it is a destructive treatment, and then we use this as a combination. That is what we all practice now. Yeah. So probably there are some specific indications where we use anti-VEGF before or after laser, before surgery.
Yeah, basically the use of anti-VEGF as an adjunct to laser ensures that your regression of neovascularization is better, quicker, and more complete. You have kind of highlighted as to where you would certainly use anti-VEGF in addition to your laser, and in that you have mentioned patients with PDR with NVI, patients with PDR with CI, centrally involved diabetic macular edema. You have mentioned, I'm just repeating it for the audience again, PDR with vitreous hemorrhages. But with that, I think we can also add PDRs with high-risk characteristics, because there also you don't want the disease to take a chance, and you want a quick regression of the neovascularization. So that also could be an added indication. And also you have mentioned that where the PRP has as such not led to a complete regression, obviously there also you need anti-VEGF.
I think it's important that the take-home message should be very clear. Anti-VEGF monotherapy can be given, but it's like catching the tiger by the tail. Once you've caught it, you can't leave it. If you start the patient on anti-VEGF treatment, monthly follow-ups are necessary. Treatment is needed every month or two. On an average, a patient who has, say, diabetic macular edema with PDR will require 14 injections over 2 years. So when you counsel, you have to counsel that, look, you need to come every month. You need to take the treatment as necessary, and that necessary could be something like 14 injections in 2 years. And if you miss these injections, there is a 50% chance that you will return with a traction detachment, and you may end up with an inoperable eye. This is very important because even in protocol S, some 30 to 40% of patients did not follow up over the entire study period. So don't take monotherapy lightly. Yeah. The better alternative is what was just being discussed: give combination. Combination therapy takes away the risk involved with monotherapy of anti-VEGF, At the same time, it takes away part of the risk involved with the lasers. See why lasers से क्या problem है? Actually, if you look at it, even protocol S could not find vision में कोई difference नहीं है. Okay, let's be very clear. Vision is the same because they took patients with 6/6. Vision कहाँ से कम होना है? तो विजन तो DME वाले पेशेंट्स में कम होगा ना, विदाउट DME वाले पेशेंट्स में तो कम नहीं होगा. तो विजन इज नॉट द इशू इज अबाउट yeah. So now you have a patient and you want to give him PRP, you are worried about the field. First factoid. In the UK, they found that more than 88% of patients who had a PRP in both the eyes were able to pass the driving test. So obviously not such a big issue. Secondly, you want to decrease the involvement of the central 30 degrees. Up to arcade is 15 degrees. Normally your laser starts from the arcade. Go 2 disc diameter beyond that and do your laser. And use the anti-VEGF agents to cover the rest. Now after that, if there is some small little neovascularization still persisting, in that small area you can do a direct laser. Your field will be preserved for more than 30 degrees. Your loss will not be there, and you have the advantage of complete regression. And even the PRIDE study actually showed that the chance of maintaining the regression was higher when you did combination therapy.
Sir, can I have some clarification? You said we will do the targeted laser to the area of which has a front. But if you look at it, unlike the vascular retinopathies like BRVOs where the disease is more localized, this is a systemic disease. So do you suggest, you said na, there is a front that you can restrict your lasers to that.
I said the PRP that you do, instead of going posteriorly, go more anteriorly. After all, where is the ischemia? Anteriorly. So if you have to go by history. Why did the ETDRS do up to the equator? Because the lens we had could only go up to the equator. Today, I'm not going to stop at the equator. Go beyond. Go towards the aura as much as you can. So all your ischemia is covered. Posteriorly, do less. Don't go up to the arcade. Go 2 disc diameter above the arcade and below the arcade. That means you're sparing a 30-degree field in the center. Now you've done all this. Now you do 3 months later a fluorescein angiography, and you find there are some fronts which are there at the posterior edge of your laser. In that localized area, you can do laser after giving an anti-VEGF.
Yeah. And reverse also, when you have done a reasonably good laser and still some of the new vessels are not regressing, probably an anti-VEGF along combination can help you.
So that's another situation. So once you've done an adequate PRP and you get a persistent neovascularization, that if it is raised, it needs anti-VEGF agents. If it's surface neovascularization, a direct laser can happen. Similarly, as far as the sequence of how to do laser and anti-VEGF, if I have a patient with raised neovascularization, no previous laser, now this patient is at risk of developing a TRD. So here I will first complete my laser, and after that go and give the anti-VEGF agent. Absolutely. On the other hand, if I have small areas of surface neovascularization, I'll give the anti-VEGF agent and quickly complete the laser after that.
Yeah, another thing in which the anti-VEGF adjuncts helps the PRP is that the anti-VEGF, not necessarily one anti-VEGF, maybe 2 or 3 shots of that in these PDR cases, will also reduce the diabetic retinopathy severity score. So chances of NV coming back is lesser if you have used an anti-VEGF adjunct.
But remember one thing, now this is where you have to be very careful. On a clinical examination, the diabetic retinopathy severity score becomes less. But if you do a fluorescein angiography for these patients, the capillary non-perfusion remains the same. That means that time bomb is still there. It doesn't go away. So you should still monitor the patient and if required, do the laser.
But parallelly, there are some studies which show that with anti-VEGF, the retinal non-perfusion areas tend to shrink a bit. There are studies which...
A little bit, but not completely.
Yeah, but your point is well
taken, I would go with Dr. Arnab, sir, regarding the same thing. If you look at, I do treat as a monotherapy in certain selected cases of early PDR, I should say, where you have a single front which is not unlikely to cause much of attraction, we do definitely do a baseline fluorescent angiography to understand the extent of ischemia in this case.
That too
We
wide
do
field.
wide field angiography, yes, most importantly. Once you do that, also you do a means a collage of a OCT angiography. Once you have charted this out, there is not significant traction. We go ahead with anti-VEGF treatment as a monotherapy in case certain cases. Which cases? Now these are the people like people from our own profession, our own colleagues from other profession who trying to understand the importance of follow-up. And in these cases, I might not necessarily go with the Ranibizumab because it needs every 4 weekly injections. I have jumped on to Brolucizumab where I inject about 8 to 10 weekly with a very careful follow-up of 6 weeks. So this is what at the most. But if you see this patient does not understand the importance of coming week, month, 4 weekly back to you, it is
Dangerous.
dangerous.
So the key message is, if the patient you feel will not follow up, please don't do monotherapy.
Exactly.
If the patient you're sure will follow up, then do that, and then keep this follow up on a regular basis. And in fact, it's not just the baseline angiography. You need a repeat angiography after
Exactly.
3 to 6 months to see whether it's gone
White
away or
field
come
that
back
too.
again.
Again, and it should be a white field angiography. It should be done.
And anti-VEGF injections try to avoid if there is lot of fibrosis in the retina.
You
Because a
forget,
lot of- yeah,
not avoid. No,
nahi,
you
we
cannot.
forget, because a lot of medical retina people, they keep injecting in even in cases with lot of fibrous tissue. So this is another point.
May I add one point? I mean,
Of
little
course.
bit, not PDR, but talking of DME. I mean, diabetes as such is a depressing disease. Patients are quite troubled with the manifold systemic issues that they have. So when we advise them injections for diabetic macular edema, obviously initially they're okay. Then that frustration creeps in. That how many more? But I mean, what Dr. Dinesh Talwar so nicely highlighted, and I also quite highlight the same to my patients, is that if we are dealing with your disease aggressively, you control your systemic parameters well, with time the disease will ease out. This is something that we need to highlight, that the first year is your toughest, second year is more or less tough, but third year onwards it will be much better and easier.
It's a carrot and stick.
Yeah.
You do your treatment regularly, the carrot is going to come.
Yeah.
You don't take it regularly, keep taking it.
Right.
I tell them, you don't come, if you don't want to take, you come once in 6 months, once in 4 months, no problem. Every time you come, I'll give you the injection, nothing will happen. It will continue throughout your life. You come to me month after month, take the treatment as required. You may need 6, 7 injections, 8 injections in the first year, but it will go down to 3, 4 injections the next year. It will go down to 1 or 2 injections the year after that. So if you want the treatment to go away, you will need to do regular follow-ups. And it works both ways. You see, what happens is anyone spending so much money on anti-VEGFs also controls his diabetes, also controls his hypertension, also controls the lipid profile, and everything works together to give him a long-term success.
Right.
If I have to add something, the biggest thing we still underspoken about is the hyperlipidemias. This is the most important thing. Control their hyperlipidemias, and you will see a lot of these plaques get over, the hard exudates which are there. Pay equal attention, if not more, to the hyperlipidemias. That's where the whole story would be. Overall, the effective part from the systemic control. And there are a lot of people who are great advocates for diabetics becoming vegan. I'm not a great advocate, I'm not, but it has worked. And there's a big bunch of people, I have colleagues who have converted their diabetic patients into veganism, and their neovascularization has reduced, their dependence on the intravitreals have reduced, the laser has reduced. This is a factual evidence.
Yeah, any form of, see, these are all systemic diseases. We label it as diabetic retinopathy, but we need to understand the play of the other associated systemic disease. So the first step in management, be it of a diabetic macular edema or a diabetic retinopathy, is control of the systemic diseases, call it a form of hypertension, dyslipidemia, the renal conditions, all have to be hemoglobin, other thing which we need to take care in our country, especially the rural population. You would be surprised, you are treating with an injection, and you never bother to do a hemoglobin, and later on you realize the hemoglobin was only 7, 6, and you treat him for anemia, and the edema just goes off without even an anti-VEGF. So this is not an uncommon situations in our country. So taking care of the systemic disease is prime and the first step towards any treatment of be it a diabetic macular edema or diabetic retinopathy, I believe.
And that nephrologists are becoming a little more finicky about giving anti-VEGF. I mean, they are against, after one article came a long time back, 5-6 years back in Kidney International, that it causes worsening of nephropathy status. Recently, I got 1 week back another meta-analysis of studies, and it does not show any change in nephropathy or renal status after anti-VEGF injection. But the Ranibizumab is the safest among the anti-VEGF injections. At present, the evidence points to Ranibizumab, and it is quite safe. That is what the studies show, especially in diabetic patients, where they may already have a nephropathy. That is absolutely.
So I think we had enough of discussion. Any question from the audience for any one of us? Yes, sir. Please.
We have lots of recurrent CSR in our practice. So, in case of recurrent CSR, what was the treatment schedule, sir?
Actually, sir, there is no evidence of anti-VEGF in CSCR, except in a small percentage where CSCR with PCN, pachychoroid neovasculopathy, is documented by OCTA or some other. So this is actually a spectrum of diseases. CSCR comes on one side, PCV comes on the other side. In between, there is a spectrum with PCN, pachychoroid neovasculopathy. Other than that, there is no evidence of anti-VEGF in CSCR. So this is the current standard. Correct, no, sir?
Yeah, so basically, if you see a patient with CSR who has cystic cavities in the retina, along with the fluid, and some kind of amorphous material, which is inflammatory material, these are the kind of patients, or the patient has a kind of a vascular change on osteangio. These are the patients who may respond, and they respond better not to ranibizumab. This is one group where it's not ranibizumab, it's either aflibercept or brolucizumab which seem to do a better job. But in a normal patient of CSR with only a neurosensory detachment, clean RPE, nothing will work.
Yeah, so on an OCT, you need to look at the retinal pigment epithelial layer integrity and the changes beneath it in the choroidal layers. If you see that to be normal, there is no pachychoroid, there are no big vessels into it, RP integrity is maintained, then it is 100% simple CSR which needs to be managed in a standard way. First line is conservative management, and then the NSAIDs and other. Yeah. So I think we had a good discussion about it. So it's time for me to thank on behalf of all the speakers, Dr. Dinesh Talwar and Dr. Himanshu Mehta, for having wonderful cases and the wonderful lectures they had for all of our audience. Let me also thank my co-moderators, Dr. Arnab and Dr. Mahesh Gopal Krishnan, and last but not the least, the sponsor of the session, the Novartis. Thank you.